Welcome to this educational activity on relieving the burden of insomnia. Dr. Paul P. Dogramji, Senior Family Physician at Collegeville Family Practice and Medical Director of Health Services at Ursinus College in Collegeville, Pennsylvania, discusses strategies for improving recognition and treatment of insomnia in the primary care setting. The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/HQB860. Downloadable slides and practice aids are also available.
So let's talk about insomnia. Well, actually, before we talk about insomnia, let's talk a little bit more about sleep. What's sleep for? Sleep is for what I call the 4 R's: rest, restore, rejuvenate, and repair. But you know, folks, sometimes sleep can get broken. There can be something wrong with sleep. And specifically, we're going to talk today about the problem of broken sleep, insomnia. So what's insomnia? By definition and by symptom, it's difficulty getting to sleep and/or trouble staying asleep with adequate opportunity and circumstances for sleep with daytime impairment. So these are the symptoms of insomnia. That's what we're going to be talking about. So you might say, all right, sleep is important, but not that many of my patients complain of insomnia. Well, look at this. National Sleep Foundation. I'm proud to be on the board of directors there. It's a nonprofit organization where we gather information about sleep and disseminate information about sleep to the lay public and to clinicians. And this is one of the polls that we did a couple of years back. And the polling question was, how often do you have trouble getting to sleep or staying asleep or are dissatisfied with your sleep? The numbers were surprising and quite staggering. 1/3 of adults said that they have trouble with their sleep every night or almost every night. 21% said a few nights per week they had trouble with their sleep. And if you add this together, more than half of American adults said that they had trouble with their sleep at least a few nights a week. We thought this was unbelievable. Now you might say, well, you know what, I don't see that many patients in my practice who have sleep problems. Not that many. Nobody comes to me talking. Maybe now and then. I saw 20 patients today, maybe one person had problems with sleep. Well, look at the pie graph on the right-hand side. The proportion of patients with insomnia who discuss symptoms with their healthcare providers, 70% never do. They never discuss it. 5% may specifically come to you and say, yeah, I want a treatment for some insomnia problems. And maybe 26% will mention it during a discussion of a different problem. But clearly, the majority of patients don't want to discuss it. Well, so you may be at a mixed emotion right now. On the one hand, you know that sleep is important and you want to relieve the burden of insomnia. But on the other hand, who wants to talk about sleep with their patients? I mean, after all, it may result in a scheduled medication that you don't want to prescribe, right? That's what we're going to talk more about, and hopefully at the end of this talk you'll feel a lot more comfortable wanting to identify your patients who have insomnia and doing something good for them to help them with their 4 R's, the rest, restore, rejuvenate, and repair. Why? Well, there's an economic burden. A recent study suggested that due to presenteeism, absenteeism, prescription and OTC medications, alcohol as a sleep aid, transportation for consultations, healthcare consultations, could be in the billions of dollars. And interestingly, just increasing nighttime sleep duration from less than 6 hours to 6 to 7 hours could have a massive impact in increasing the lost dollars. Now let's take a look more clearly, though, at the impact of insomnia as it means to the patient. Insomnia clearly has an impact on daytime functioning, with drowsy driving, causing fatal car accidents, also injuries and accidents at work, decreased quality of life, increased presenteeism, and increased absenteeism. These are all impaired daytime functioning. But this may surprise you, that if a patient doesn't get the 4 R's, the rest, restore, rejuvenate, and repair, they are much more likely to have psychiatric and medical problems. They are much more likely to have depression, stroke, diabetes, coronary artery disease, obesity, suicide attempts and other psychiatric problems, hypertension, overall mortality. If you don't sleep, bad things can happen to you. It's imperative, therefore, that we identify our patients who are having sleep problems and doing something for them. Again, just because they don't mention it now, we no longer can say we don't want to talk about it. We need to proactively ask our patients if they are having problems with their sleep when they come in for certain visits. Now let's take a look at risk factors and contributing medications and substances for insomnia. Who are those that are at higher risk for insomnia? Well, you should be more alerted to the possibility of insomnia with those who are older. Older adults are much more likely. Ask more questions to older adults about their sleep. There's a tendency also for insomnia problems to occur more in women than in men. Those who have more comorbid conditions. Those who have more stressors in life. Those who are doing shift work, and those with lower socioeconomic status. So who do we ask about their sleep problems? Maybe we go and gravitate more towards these types of patients than just all patients in general. We also need to know that there are some things that patients do or we do to them that can impact their sleep, like patients who are using stimulants, antidepressants, decongestants, opioids, cardiovascular medications, pulmonary medications, and also alcohol. These are some of the risk factors and contributing aspects for insomnia. Now, I talked about comorbidities earlier, and I said that insomnia is a contributing factor for medical and psychiatric problems. Let's call these comorbid conditions. Certain medical problems, certain psychiatric problems are much more likely to occur in patients who have insomnia. Cardiovascular disease, endocrine, neurologic, psychiatric, pulmonary, gastrointestinal, musculoskeletal, genitourinary, reproductive, sleep disorders, etc. You need sleep for all parts of your body to be healthy, and when there's poor sleep, any part of your body can malfunction. Now, you might be thinking, well, in which direction does it go? Does insomnia cause these, or are these problems causing insomnia, or which direction does it go? Well, interestingly, it could be one direction, the other direction, or both. Let me give you an example. So, for example, neurologic headache. Patients who have migraine headaches, when their migraines are out of control, they're much more likely to have insomnia. But on the other hand, if their migraines are controlled and then all of a sudden they develop insomnia, they're much more likely to have migraine headaches. So there's a bidirectionality there. And let's take psychiatric disorder, depression. Interestingly, patients who have insomnia are much more likely to have depression, to develop depression. And patients who have depression are much more likely then to have insomnia. Let's take a look at a case presentation. Angie. She reports difficulty maintaining sleep. She's a 40-year-old African-American woman. She recently made partner at a law firm. Her bedtime varies between 10 p.m. all the way to midnight, but she falls asleep pretty easily and relatively immediately. But she wakes up at around 2 a.m. every night. She lies in bed, drifting in and out of sleep until finally at around 5 o'clock in the morning, she needs to get up and get ready for her day. As a result of this, she's forgetful, she's fatigued, she's slow to complete the task. It's clearly affecting her daytime functioning. Her symptoms started when she became partner 6 months ago. She drinks 6 cups of coffee per day, wow, but is unable to stay awake sometimes even during client calls. My gosh. She wants something to help her sleep through the night. So this is one of the rare 5% of patients who comes to you saying, I want something for my sleep. So what do we do when a patient comes in like this? You take a good, thorough sleep history. You obviously ask about trouble getting to sleep and staying asleep and next day consequences, but also let's look at some other factors in patients like this. When did the symptoms first occur? The frequency and severity of the symptoms, the duration of sleep time total, contributing and perpetuating factors. These are all important aspects of our patients with insomnia. You should go into other things as well, like tell me about your bed situation. Is it comfortable? Who else sleeps in your bed with you? What do you do before bedtime? Do you use any kind of screens like television or computer or laptops or those kind of things around sleep time? So these are all the different things that we need to ask for our patients. And don't forget to ask, what have you been doing about your sleep problem? Okay. Let's go into a couple more things about Angie's medical history and her insomnia history. She's a diabetic, type 2. She's had no surgery. She's a non-smoker. She drinks 1 or 2 or 3 glasses of wine on weekends. She has no caffeine after 4 p.m., but she gets her fair share of it before then. Her medication are those 2 that are used for diabetes, type 2 diabetes. She's maintaining a good BMI. Her physical exam, she's anxious, but otherwise okay. Her lab testing that was done in the past year, pretty much normal, including an A1C, which is 6.3. She's in pretty decent diabetic control. She does stop using blue light devices like phone and tablet and laptop an hour before bed, so she knows to do that. She's not using any OTC sleep aids because she says those are for people who have trouble falling asleep. She feels irritable, and you can see that. She's tense. She's on edge. She says that this is especially the case at bedtime. She gets anxious about not getting enough sleep, and sometimes that may interfere with her in the middle of the night when she gets up and she's anxious about her sleep itself, and that perpetuates her insomnia. So if somebody comes in with insomnia, how do you go on to assess what the patient actually has and what to do about them? Well, there's a DSM-5 diagnostic criteria. I'm going to go over that in a few minutes with you. A couple of things that may also help you with your patients, which is a sleep diary and an insomnia severity index. Those two I'm going to show you for Angie, our patient. If a patient does exhibit symptoms of depression or anxiety, there are some scales that you can use, like a PHQ-2 or a GAD-7. Now, testing isn't really going to be necessary for somebody with insomnia. Just doing the history taking and observing the patient is going to be enough. But in certain instances, blood testing may not be a bad idea. Like if a patient has restless leg syndrome, you do want to do a ferritin level, or if they have other kinds of neurologic disorders, you might want to do a complete set of blood tests. The majority of patients are not going to need anything. If you suspect periodic limb movement disorder and if you suspect obstructive sleep apnea, you are going to need a sleep study. I said earlier that I would go over the DSM-5 diagnostic criteria for insomnia, and let's do that. Insomnia is a dissatisfaction with sleep quality or quantity with one or more of the following: difficulty initiating sleep, difficulty maintaining sleep, early morning awakening with inability to return to sleep. So this is the diagnostic criteria for the disorder of insomnia, but it must also have significant distress or impairment. It's got to occur 3 or more nights per week. It's got to occur or been going on for 3 or more months. There has to be adequate opportunity for sleep. It's not better explained by or solely due to another sleep-wake disorder, and not attributable to medication or substance use, and not adequately explained by comorbid medical or mental disorders. So this is how you make the diagnosis of insomnia, the disorder. Let's get back to Angie. So with Angie, we give her an insomnia severity index, and we ask her about your difficulty falling asleep. She says none. Difficulty staying asleep? Oh my God, a 4. Problem waking up too early? That's a 4. Satisfied with current sleep pattern? Not at all. That's a 4. Symptoms interfere with daily function? That's a 3. Noticeable impact on quality of life? Much. That's a 3. And worried about sleep problems? That's a 4. You add the whole thing up, it's a 22. You say, Angie, you have severe insomnia. And she probably is going to say to you, Doc, I told you, I'm really having a lot of problems with my sleep. So quantifying sleep with an insomnia severity index may not be a bad idea. But another thing which you can do is give Angie a sleep diary to keep for about a week or so, especially if you're having a little bit of difficulty with trying to understand her sleep pattern. And interesting, when you do something like this for her, she can understand her sleep pattern better and already start to work to correct certain things. So look at this. A is for alcohol, C, caffeine, E, exercise, M, medication, down arrow, going to bed, up arrow, out of bed, orange boxes, naps or nighttime sleep. So just looking at this, you can kind of see that her sleep is all over the place. It certainly is less in the evening when you want her to have the sleep when sleep time is desired, but there's sleep in other times as well. And look at the C on the left-hand side. There's C all over the place, caffeine all over. There's a little bit of exercise here and there, and there's some alcohol here and there, but you can clearly see that Angie is really struggling to get her sleep during the sleep times that she wants. So we've talked about insomnia as a disorder, that it's quite prevalent. It's very disturbing to a patient. It can impact the quality of life, and it can certainly be a risk factor for medical and psychiatric problems. What's the first thing that you do with a patient with insomnia? You educate them. You tell them how important sleep is and how dedicated you are to help them get to a better night's sleep. But in order to do so, they need to participate. And their participation starts with proper sleep hygiene, good sleep behavior. So most important, first and foremost, is awakening the same time every morning. This sleeping in on weekends, varying sleep time, doing cat naps, not a good idea. We need to train the brain. The brain clock needs to be told when it's supposed to get up in the morning, and that's a very important thing. The next important thing is when to go to bed. And when is that supposed to happen? When the person is tired. Okay, so go to bed when you're tired and get up the same time every day, weekends and weekdays as well. Very important to tell your patients that. But a couple of other things. Establish daily routine activities. Exercise is a very good thing. Taking walks throughout the day is a good idea, but not late at night, because sometimes exercise within 3 hours of bedtime can be activating. and could prevent somebody from actually getting to sleep or staying asleep. So there are a bunch of things that a patient can do as far as what we call good sleep hygiene. Now, sleep hygiene is part of something that we call cognitive behavioral therapy for insomnia. So this is where a sleep coach, a cognitive behavioral therapist for insomnia, works with a patient to establish better sleep habits and get rid of their insomnia. And this is typically done by a trained provider to individuals or in groups from 6 to 8 sessions, usually once a week or so, lasting about 45 minutes to an hour. It improves the time to sleep onset, decreases time awake after sleep onset, and provides benefits for 6 to 12 months after treatment is complete, and sometimes even longer. So it's quite permanent. And basically, what does it do? And look at the fourth one there. It restructures maladaptive beliefs about consequences of insomnia, and this is a very important part of cognitive behavioral therapy. And let's go back to Angie again. So Angie is counseled on sleep hygiene and referred to a certified cognitive behavioral therapist for insomnia. She returns to the office 3 months after that, and she says, look, my night awakenings have decreased from every night to 4 times per week. It's a little bit better. My daytime anxiety has improved. I'm working a little bit better during the day. I'm feeling a little bit better. But I'm anxious at bedtime, and after awakening up at night, I'm still feeling kind of tired, and I still have some trouble concentrating at work. It's better, but it's still there. So the symptoms have improved, but they've plateaued over the last couple of weeks. So we're getting better with her, okay? But we're not where we want to be, and perhaps it's a consideration now to talk about medication. These are FDA indications and American Academy of Sleep Medicine recommendations. So on the left are the 5 different classes of medications, the benzodiazepines, of which we're going to talk about triazolam and temazepam, benzodiazepine receptor agonists, esopiclone, zaloplam, zolpidem, zolpidem extended release, and zolpidem sublingual. Melatonin agonist, in that category there's only one, Ramelteon. Histamine receptor antagonist, again only one there, doxepin. And orexin receptor antagonist, the FDA indications are there, and the American Academy of Sleep Medicine recommendations are next, and then the scheduling is next. Couple of things of note. These medications recommendations as far as onset and maintenance have to do primarily when the medication is going to take effect and how long the medication is going to take effect. So let's take, for example, zaloplam. The medication is rapid onset, but also leaves the body very quickly, so that's very good for somebody who just has trouble getting to sleep. But let's take another situation where somebody has no trouble getting to sleep, but wakes up and can't get back to sleep again. In that instance, doxepin, low-dose doxepin, would be a good idea because the medication is intended to help somebody just stay asleep. So there's all these different indications for the different medications here, and it's important for you to go over them. Look also at the scheduling. 2 of these medications are unscheduled, and that may be very important because there's a lot of times when our patients have other scheduled medications that they could be using, and you don't want to add another scheduled medicine on board. So there are 2 that are unscheduled. There are some adverse reactions to these medications, and I want to only call your attention on this to the black box warnings. Benzodiazepines have black box warnings. Benzodiazepine receptor agonists have black box warnings. The other 3 do not. A couple of other things that you need to know about pharmacologic treatment for insomnia. And these are additional American Academy of Sleep Medicine recommendations. There's no specific guideline recommendations or inadequate evidence for other benzodiazepines approved for insomnia, such as estazolam, flurazepam, and quazepam. And agents used off-label for insomnia, oxazepam, quetiapine, gabapentin, and paroxetine. But AASM clearly does not recommend for insomnia OTC supplements like melatonin, L-tryptophan, and valerian. It does not recommend diphenhydramine, and it does not recommend trazodone and tiagabine. So AASM, American Academy of Sleep Medicine, does not recommend those for insomnia. So in choosing, what do you look for? I suggest to you the first thing you should look for, again, is does the patient have trouble getting to sleep, or does the patient have trouble staying asleep? Or if the patient has both. And start there and choose the medication from the table that I just showed you. Also ask for a couple of other things. Hey, what has worked for you in the past? Let's take a look at that. So response to prior therapies. Comorbid conditions. If, for example, a patient has respiratory problems like COPD, you might not want to use a medication that has respiratory suppression like a benzodiazepine. Potential medication interactions, adverse effect profile, patient preference, cost, risk for dependency. These are all factors to consider as to which medication you choose for your patient with insomnia. Let's go back to Angie. So you start Angie on esopiclone 1 milligram, which is a starting dose, and it's the right dose that the FDA recommends. 1 milligram at bedtime, and she continues her CBTI practices. She returns in 5 weeks, and what does she say? She says, you know, the esopiclone, it does make me feel drowsy at bedtime because I take it right then, and I'm able to get to sleep really easily like I was, but I'm still waking up at night 4 times a week. It really hasn't done as much as what I wanted to, doc. Let's now talk about orexin receptor antagonists. Orexin, a neurotransmitter, was discovered about 20 years ago or so, and it was actually discovered by 2 different laboratories. One laboratory calling it orexin, the other one calling it hypocretin, because it's located right underneath the hypothalamus. So hypocretin or orexin. It was thought to maybe be involved in physiological roles with sleep and wakefulness, feeding and appetite, reward pathways, that sort of stuff. But what was very interesting about it is that we found that in patients with narcolepsy, they have no orexin whatsoever. So interestingly, it was now found that orexin is a wake-promoting neurotransmitter. In order for you to be awake like you are right now, you need orexin. What was then discovered is that during sleep time, orexin activity is dramatically decreased. So in wakefulness, orexin sends signals throughout different parts of the brain to activate it and to keep it in a wake active neuron process. But during sleep, the sleep active neurons are active and orexin becomes relatively inactive. So, what can we do now? Let's capitalize on this. Let's see, in our patients with insomnia, maybe we can suppress orexin, reduce wakefulness, and as a result, help them get a better night's sleep. And in fact, this does translate in reality to be the case. So, outcome, 4 different medications that are orexin receptor antagonists. These are all dual orexin receptor antagonists. There's Suvorexant, Lemborexant, Diagnostic, and Celtorexant. And these 4 are not all approved. Let me show you one interesting thing about Suvorexant. This was in the phase 3 trials for Suvorexant. It showed that the medication does help in wake after sleep onset, which means that it helps with sleep maintenance. Patients are not only able to get to sleep better, but also stay asleep very well with this medication. Some side effects can occur with any medications, including this one. There's some somnolence, headache, dizziness, etc. But as a general rule, the medication does quite well as far as overall side effects are concerned. Now, let's take a look at Lemborexant, Sunrise 1 and Sunrise 2. Sunrise 1 was 5 milligrams and 10 milligrams versus not just placebo, but also active comparator zolpidem. Very interesting that in that study, that the 5 and 10 milligrams were seen to be superior in helping patients get to sleep and stay asleep. The Sunrise 2 study, it shortened sleep latency and improved sleep maintenance. Lemborexant was seen to have some side effects, as all medications could, but relatively minor. Some somnolence, headache, and some other kinds of side effects occurred compared to placebo.
Based on data from Sunrise 1 and Sunrise 2, the U.S. Food and Drug Administration approved Lemborexant 5 milligrams and 10 milligrams on December 23, 2019, for the treatment of adult patients with insomnia characterized by difficulties with sleep onset and/or sleep maintenance.
In phase 3 updates from World Sleep Congress 2019, new data demonstrates safety and tolerability of Lemborexant over a 12-month period and qualitative persistence of Lemborexant effectiveness through 12 months. And the mean ratings for quality of sleep and morning alertness showed improvement from baseline through 12 months with both doses of Lemborexant compared with placebo. Qualitative persistence of improved sleep quality and morning alertness after 12 months also observed. Now, in the Sunrise 1 study, which I said earlier was not just 5 and 10 milligrams pitted against placebo, but also against zolpidem, which was active comparator, Lemborexant treatment resulted in improvement of sleep architecture with increased time in all stages and reduction in REM-L compared with placebo, and was superior to zolpidem for most measures. Very interesting. Okay, let's go back to Angie. So Angie starts pharmacologic therapy. You discuss with her switching to an orexin receptor antagonist, and she says she wants to continue with all the CBTI stuff that she's learned, but she agrees to try another pharmacologic agent. She returns to you after 2 months, and she's now sleeping through the night and all days of the week. She's still experiencing some occasional fogginess, but things are better. And she maybe has some headaches, but again, things are better. She, at this time, doesn't want to try anything else. Things aren't perfect, but I can function. So we've done quite well with Angie at this time with switching her to Severity. Some takeaway messages. Taking a medical history combined with an insomnia history can facilitate a diagnosis of insomnia, and using tools like a sleep diary, insomnia severity index can certainly facilitate understanding what's going on with the patient and what direction to then go to. The insomnia treatment landscape continues to evolve. Suvorexant is FDA approved for patients with sleep onset insomnia and sleep maintenance insomnia. Lemborexant, also dual orexin receptor antagonist, has shown promise in recent phase 3 clinical trials designed to evaluate its safety and efficacy, and other potential orexin receptor antagonists are being evaluated in clinical trials. I suggest that the future of insomnia treatment is probably going to be primarily these orexin receptor antagonists. With that, I've come to the end of my talk. I hope that you have found it enjoyable and informative about insomnia in your patients to help them understand their condition and treat them as best as possible towards their best night's sleep. Thank you very much.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/HQB860. This activity is supported by an educational grant from AASM Incorporated. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.